We're hoping to make this a really interactive time for us to all be together and really work on concrete things we can do to improve maternal health in Pennsylvania. Thanks so much. And I believe I'm kicking it over to Dr. Ramirez.
Thank you, Ashley. Hi, everyone. I'm super excited to see so many faces. I think many of the faces here are new. At least I can't remember those before. And so I'm going to give just a brief overview of things we've already discussed. So let me share my PowerPoint here. Um, so I am Sarah. I am Associate Professor of Family and Community Medicine. I also am a unicorn family doc who also does higher risk obstetrics, delivers babies, etc. And I do a lot of research. I'm at Penn State. I am founder and president of the Penn State Hispanic Professional Association, as well as the founding chair of the Pennsylvania chapter of the National Hispanic Medical Association. So, should you know any Latino healthcare providers or folks who would like to join, send them my way. And I'm on the board with the Family Medicine Education Consortium, FMEC, Scott, the CEO, and that group really being the lead for our initiative. So I'm happy to see everyone here. Over the next 10 to 15 minutes. Oh, there's an echo. Do you hear an echo? Oh, I don't know what happened.
Renee, could you mute, please? Renee Nagel.
Okay. Thank you, Ashley. So over the next 10 to 15 minutes, my hope is that this will not just be me talking to all of you, that this will be really a conversation, because when the founding team got together to talk about, this is the founding team of the PA Collaborative, Maternal Health Collaborative. Our goal was never to be the all doers. Our goal was really to be kind of a facilitators of bringing people together, almost the connectors, and uniting and bringing us across Pennsylvania together to affect change. We know the data. I'll show some of the data a little later. We know the data is not great for our state. We know folks are doing things about it, but because we're so large, there are many silos. So one of our goals was to come together and see how could we strengthen the efforts by doing that. So our founding team is made up of this group here. I wear several hats, so some of these pies are represented there, and then you can see that. But the agenda for today is we're going to really try to highlight you all, the partners involved. Should you, throughout our conversation this afternoon, start thinking about other people who are missing at this virtual table, and who you feel might be good voices to hear from, please send them our way, and we would be happy to either connect, or if you would like to send a connecting email and connect us to them, that would be great. I'll be focusing on goals of our collaborative as well as showing some data. And then later, we're going to talk about state health improvement plan and two examples of maternal health success in action. Then we're going to have time to break out into groups, and then we're going to adjourn. We're going to talk about next steps and adjourn our meeting. So first, let's talk about the GRIM data, which we're all familiar with. This is the 2024 MMR, which many of you are probably familiar with. So in Pennsylvania, the pregnancy-associated mortality ratio by demographic, is 83 per 100,000. But when we break that down by race, ethnicity, the grim reality is that almost 150 per 100 live births in our state are attributed to those who identify as Black or African American. And according to this report, postpartum hemorrhage being the highest complication rate amongst those. There's some data that, that looks at that a little further. And then after, also renal complications having the greatest increase over time since 2016. Now, this data is really limited in terms of timing. I know that there are folks that are looking at more updated data. So I wanted to pause at this slide and find out from all of you if you are looking at data within your own groups, if you're looking at data in your regions or across the state with different databases, because one of the other goals for bringing us together as a collaborative was finding out what people are already doing and how do we spread that amongst the state. So I'm going to pose a question to all of you. When you answer, if you could tell us your name and where you hail from, and share with us if you have more updated data. Not really. I hear a whisper of not really. I don't know if that was intended for us to hear or.
Hi, Sarah. This is Giselle Halden. I just wanted to clarify this a little bit that so the figure on the top is maternal mortality and the figure on the bottom is maternal morbidity. So
Right.
they're two separate things, and the leading cause of maternal mortality is mental health and substance use disorder, and then the leading cause of severe maternal morbidity is hemorrhage in this thing. So I just wanted to make sure it was clear to everybody that they're looking at two different things.
Right, right. Thank you for that. Do you have any updated data from what's shown here? I know that folks in implicit are doing their own analysis, looking at more recent data.
Yeah, so we just finished review of 2021 maternal deaths in November. So the new report will be coming out soon. So we do have it, but we don't have it all pursed out just yet. I can say that the leading cause of death, again, is maternal mental health and substance use disorder. And I have not seen the rates for severe maternal morbidity for 2023. So I cannot speak to that, but.
Thank you. And I know that at some point there is data out there looking at postpartum period and at which point within that fourth trimester, the first 12 weeks postpartum is the rate the highest. I believe I remember seeing postpartum days 7 to 42 at one point. In your analysis, do you all look at that, or is anyone in the group aware of more updated data?
We do look at that. I don't know for 2021 off the top of my head. I don't know if anybody else can speak to that, but we do look at the timing, and what we see is that deaths very soon after pregnancy tend to have a sort of medical issue associated with them. And then not that medical issues don't occur, later in the pregnancy, but we see a lot more mental health related challenges in the later period of that year after the birth. So
yeah, thank you,
Giselle. Giselle, this is David. You might want to identify yourself.
Hi, David.
Not as
like who I am and why I know this?
Exactly.
Oh, okay. Hi, everybody. My name is Giselle Halden. I'm the director for the Division of Maternal Health Services in the Bureau of Family Health, which resides in the Department of Health. And I help to oversee the maternal mortality review program, which reviews all cases of pregnancy-associated death that occur in Pennsylvania. And that pregnancy-associated death is any death that occurs during pregnancy or up to 1 year after the end of the pregnancy. So,
yeah. Thank you, Giselle, because I didn't know who you were.
Sorry.
But thank you. No, it's okay. So, I think what's important, and this is a really good conversation, because as we determine what is step one, narrowing things down and having the clearest data is really going to be helpful. So I think what's important from what I remember looking at that data postpartum, the highest mortality postpartum, a lot of it was related to like hypertensive disease. And we know that 5 or 6 days postpartum is when we're going to really start to see those peaks in the blood pressure, which is why you want to capture them in the office. So it might be helpful, and I don't know if you're doing this already, is to look at this data by medical condition, in terms of where are we seeing these spikes in mortality and what are the medical conditions driving those? Because as we make the case for why fourth trimester care is so important and linking patients back to either a family med OB like me or their OBGYN, um, is going to be really key. And then looking at, you know, are there peaks in diagnoses of depression and anxiety and other mental health disorder? When does that peak occur? So I feel like these peaks are going to be really helpful in triaging them by medical condition. I see Dr. Livingston here. I'm going to call on you, to see what your thoughts are, on these ideas. Mhm.
You're on mute, Dr. Livingston.
Technology, I tell you. Such anticipation. While we're waiting for Dr. Livingston, Giselle, is that
Okay,
something that,
there we are.
oh, there you go.
Geez,
There
sorry.
you
I'm
are.
here in the office and I'm on a different computer. Yeah, I think that in addition, Dr. Livingston here, OBGYN physician, and I sit on the Pennsylvania MMRC. And I appreciate Giselle giving that update because we were all sort of shaking our head like, yes, maternal, mental, behavioral health issues are the number one cause for both pregnancy related and pregnancy associated, but not related deaths. And so the answer surrounds who you're talking to, right? If you're talking to somebody on the MMRC and CDC, we break maternal mortality down into pregnancy related or pregnancy associated, but not related. And when you do that, that gives you an idea if you're talking about a death that's related to the physiology of pregnancy, as you were alluding to, Sarah. Your cardiovascular issues, hypertension being the most prominent in pregnancy related, but pregnancy associated but not related would be a death due to something like a substance use overdose. And we're seeing a significant uptick in the wrong direction with pregnancy associated deaths due to substance use disorder. So it really hinges on who you're talking to and how we're defining maternal mortality. So I hope that helps. And I'm actually glad we're having this conversation. May I make a suggestion that maybe a standing agenda item would be an update from the MMRC so that we're kind of getting on the same page as far as definitions, pregnancy associated deaths being further dissected into pregnancy related or pregnancy associated, but not related.
Yeah, I
Dr.
like
Livingston.
that idea for sure. And that's why I'm going to create slides as we're talking, because this will prompt us to keep this in the forefront. I think it's really nice I like what you're saying, because looking at that postpartum period and the time points where we have those spikes, I think is going to be key. And where are we spiking? So I think for the teams here that are data focused and helping to generate these graphs or these data, I think it'll be really nice to be able to see, over time, postpartum days, which is the pregnancy associated condition that is at the top. I suspect it'll remain hypertensive diseases. But is it day 5? Is it 6, 7, or 8? Because then that'll help with timing with that first initial postpartum visit. And then pregnancy related, the same thing. And which of the mental health conditions are the highest? I think would be helpful, because as we report back to the teens prior to discharge, I mean, I know at Penn State we're already screening for um, depression, anxiety, but should we be screening for other things? And should we be linking people to outpatient follow up sooner? So, Giselle,
Well,
is that
60% of the postpartum deaths occur 42 days and greater.
right?
13% in the first 7 days after delivery. So
Mm-hmm.
where our opportunity, and 90% of these deaths are preventable. So our opportunity exists deeper into the postpartum
Mhm.
period. I mean, as an
Yeah.
OBGYN physician, the doulas and I say all the time, postpartum lasts forever. So we need to have
Mhm.
these conversations in an ongoing matter, um, inside and outside of pregnancy,
Mhm.
really.
Yeah.
One,
Giselle, with
one,
that,
one suggestion I might put out there before I forget it. Do we have any uh, behavioral health folks as part of this collaborative? Do we have any folks dealing with SUD?
Wow,
I don't
that's a
know if we do.
suggestion. It's a great suggestion.
Mhm.
And we have some folks connected to the Office of Health Equity, and within our department. I'm going to pick on Giselle, our substance abuse folks. I don't know how well connected they are, overdose folks, to the work of BFH and this particular aspect. Ashley Bolton and her folks.
Yeah, we do. So we use um, their, and the name is escaping me right now, but we do look in their database to see what sort of substances had been prescribed to all of the cases that we're reviewing, being that it's such a large issue. And they have used our recommendations in the past to sort of develop a training. So there is some collaboration between our bureau and hers. There can always be more, of course. And we've talked about they have some overdose review committees, but it's not like a statewide thing. So we've talked about connecting to see what we can do in that area. So there is some, we talk. How about that? We do talk.
Okay. Okay.
And to your question, Sarah, as for like determining, like when you're talking about mental health, what they necessarily were suffering from that might have led to suicide or whatever, we only have the information that we get from records and that like their death certificate, so like the underlying causes of death. So getting information at that level isn't it wouldn't be consistent, for one, like across all of our cases, because we only have what we can get to review. So I don't know that we would be able to break it down that much. If you're looking at the maternal morbidity, you would be able to sort of break it down by very specific condition that they were having issues with. But when it comes to actual mortality, it is a little bit different.
Okay. Yeah, but I do you think for that your report will be available in time for our next meeting or?
In my experience, it takes longer to get through the review process than the next meeting.
Okay, got it.
Next
As all
meeting
things
being
do.
in March.
Mhm,
Mhm.
mhm.
I just want to make sure you knew that.
Yeah,
Yeah.
I mean, the last time it took quite a while. So I'm just not going to make any promises.
No,
That
that
being
makes sense.
said, if we get requests for data briefs or things like that that have then been made public, I'm happy to come and talk to the group or
Okay.
provide it to the group so someone can talk about
Yeah.
it. Okay.
So I think that if we were to summarize, um, so pregnancy associated versus pregnancy related, I like that being kind of our parking lot, always slide item that we reflect back on and update. We're saying pregnancy related suicide being number one, second being substance use.
Just the opposite. So pregnancy
Okay.
related is something related to the physiology of pregnancy. So for example,
So
eclampsia, severe preeclampsia. So
yeah.
eclampsia, severe preeclampsia, hemorrhage
Hmm.
are examples of pregnancy related. So
Right. And then for
and
pregnancy associated, it's going to be number one from what you're learning is substance.
mental health.
Oh, it's suicide.
Yeah.
Suicide, is that
No,
right?
mental health. So like anything related to like substance use, although a significant percentage of people who
Yeah.
use substances
Yeah.
suffer with depression and anxiety. So no, it's
Yeah.
not suicide. It's pregnancy associated but not related would be
Yeah.
drug overdose,
Yeah. But
mental
I
health.
think
It's probably better to sort of just umbrella it under mental health disorders.
Yeah, the
okay.
term
So just
that I'm sorry, the term the CDC uses is mental health conditions, including substance use disorder.
Yeah,
And
thank you, though.
sure. And I will say that the more reviews we do and the worse that the, um, mental health and opioid related things get, we're seeing a lot more cases that the committee is deeming pregnancy related, where mental health and substance use disorder so there are cases where mental health and substance use disorder is pregnancy related. And
right.
in our initial 2021, the leading cause of death for pregnancy associated and pregnancy related is mental health conditions, including substance use disorder.
So thank you. And then number two is hypertensive disease for pregnancy related from your report.
Yeah, cardiovascular.
Okay. All right. I'm just trying to get to the top so we can. And then when we're talking,
I didn't remember.
and then when we're talking about maternal mortality, pregnancy associated mental health and substance use disorders being the largest one, do we know at which postpartum day do we have that data? Like which window postpartum we're seeing that spike?
We do. We break it out by 1 to 6 1 to 6. We do break it out. There are 3 different periods of time that we then break it out. I don't know what they are though.
Oh, I was gonna say, can you share with us what
Yeah,
that
no.
is? Okay, so that is to come. Data is coming soon.
Yes.
Okay, are you able to at least tell me if it's after the first 12 weeks?
To be completely honest, I am not sure right now for 2021.
Okay, that's fine.
In 2020, it was 12 weeks to 365 days or whatever our third
Okay.
breakout was.
And do we know
42 days and greater? Yep.
And do we know for your report within the first 6 weeks postpartum what the highest contributor to mortality is for 2021?
I do not right now, but we will,
Okay.
and it'll be something that we share.
It's coming. I'm pushing you. To reveal your cards, and you won't. Okay. All right. So that's as far as we can get right now, but I think it's a good start, and it's also encouraging to know that we will know at some point in the next 6 months, maybe, what that is. So I'll move on to our next slide. So as you all know, drivers, there are many social determinants of health and racism in medicine drivers to what we're seeing in morbidity and mortality, not just in our state, but across the country, including maternal health deserts, which this week I had a case of a 14-year-old who was going to be driven to me 2 hours away from her home for prenatal care because mom couldn't find anyone in her area providing care. So luckily I was able to find a place for her, though the nearest hospital was an hour away, but that was better than 2 hours. So maternal health deserts are real, and I don't think it's not getting better. So reality there. So I thought the other thing we could spend a little bit of time on, and please, David or whoever's running time stands here. How much more time do I have on my section?
Sarah, you might want to wrap up in the next 2 or 3 minutes so we can get to David and then our example program.
Okay, great. Yeah, because I'm a talker. So great. Thank you. So here are, when the collaborative we've met a little bit here and the leadership has met, and here are the overall goals of our collaborative. Should you all be thinking of things that we've missed, please share. I've talked already about engaging a diverse group. David and others have pointed out that missing from our table is a mental health provider. So that would be something that we would want to work on. And then really we're thinking of sharing, activities across the collaborative so people across the state know what we're doing, develop strategies for identifying ongoing racist practices within maternity care, ways to mitigate these. I think one thing we can do is collate any scholarly work that's coming out of this collaborative as it deals with racism in medicine and maternal health. Should you have any of that, please send them to me and I'll start collecting them for when we're ready to put that somewhere on a website and we can, read and keep up to date with what our group is doing in that respect. We do want to generate scholarship, and many of us here who are in academic medicine are always looking for opportunities to collaborate with others, to co-write, publish, because as we know, that is what helps in being promoted, but also disseminating the data and the findings. Additional goals is to continue to expand. We are still in draft mode for our mission and vision. We're thinking of a logo. Should you have interest in helping us with any of this, please reach out. And really, I think it's really helpful that we have done this exercise because one of our goals is to identify the lowest hanging fruit so we can focus kind of step one on that. And then we're further refining sharing of our information. So we currently have a website within the Family Medicine Education Consortium. We're considering a listserv or a group list, and also creating a directory of partners and programs. I don't think I can talk that. I think I've made it under 2 minutes or 3 minutes. But that's all I have. Thank you for the conversation, everyone.
Sure, you did great. So I'll jump in. My name is David Sons. I'm the director here at the Office of Health Equity for Pennsylvania Department of Health. I'm going to talk to you about the State Health Improvement Plan. Our SHIP is our roadmap to improve the health status and life expectancy of Pennsylvanians and eliminate health inequities. Our office contributed to the development of the SHIP. So I'm very excited to implement the SHIP. The SHIP was developed in collaboration. I remember years ago with a public partnership of stakeholders across the Commonwealth. So we had a lot of people involved in identifying health priorities and setting goals. The 5-year plan that started in 23 has 9 particular goal teams, and there's a SHIP goal team that is focused on improving maternal and infant health outcomes by improving prenatal, perinatal, and postnatal care. So a lot of things that we've talked about already today. This goal team has 2 objectives, specifically reducing infant mortality and reducing severe maternal morbidity. Again, we talked about that a little bit earlier. Racial disparities in adverse maternal health outcomes continue to persist here in the Commonwealth. So there's a priority population on Black women and infants. In fact, they're nearly 3 times as likely to die compared to their white counterparts. This goal team has a focus on reducing maternal and infant health disparities. And as I mentioned, identified Black women and infants as priority populations to ensure these populations are the focus of interventions. And I'll say this too, one thing that I feel pretty strongly about that I've read in all the literature that I look at, when you focus in on, the highest disparity, the toughest group to address, you impact everyone. I was speaking about actually someone that works for us that lives in rural Pennsylvania, closest to, and I think she's on this call and she knows who she is. She's could be a half an hour away, 45 minutes away from maternal care, and she's pretty far along, and you have weather conditions, so it affects everyone. But our focus is then on African American women and infants. SHIP goal team 3.4 includes maternal and infant health partners that meet. This group meets monthly to discuss and document activities. So similar to what we're doing here, and I know there are folks here that are on that particular group. They're currently underway throughout the Commonwealth to work towards their goal and objectives. SHIP members and partners are not required to take on any extra tasks. So just like we're doing here, we really want to not add on to what you all are doing, but to have a collective effort, engaging various organizations across the state so that we can meet common objectives related to your ongoing work. The SHIP is a great opportunity to join forces with other partners to amplify and impact current efforts. So if you are interested in joining this particular SHIP team, we're going to drop the link. Basically, it's an email address, it's a resource account. Reach out to join that particular group. I don't know if there's any questions related to SHIP. I have folks on the line beyond myself that know a lot about the SHIP in this particular goal team. So let us know if you have any questions. And that's it.
Great. Thank you so much, David. And I see that Tensei put in the chat the email address that you mentioned. So with that, we're going to move on to the next segment of our agenda. I think it's Sarah mentioned. We definitely, through this collaborative, we want to help put spotlights on different projects that are happening around the state so we all know about them and can connect with them. And by the way, I didn't introduce myself. I'm Scott Allen. I am the staff for the Family Medicine Education Consortium, and we're super excited to be partnering with all the great groups leading this and on this meeting today. So with that, I'm going to turn it over to our first of our two presenters for a short, about 10-minute presentation, and then we'll have a little bit of time for questions after. And our first project we're going to talk about is Mothers, You Are Not Alone. And I'm going to turn it over now to Dr. Tamar Krishnamurti, who is going to talk a little bit about that project. And you have your own slides, right?
I do, yeah.
Great.
Let me just make sure I can share them. Are you seeing my desktop at this point?
Yes.
Sorry, let me after all these years of virtual, I'm still totally useless at sharing slides. 1 second. Sorry.
Take your time.
Can you see Mayana?
Yes.
Perfect.
Wonderful. Okay, great. Well, thank you so much for inviting me to kind of share our work on Mayana today. For those of you that I haven't met, my name is Tamar Krishnamurti, and I'm so glad to be here to kind of let you know about the work we've been doing in the digital health space to build supports for peripartum individuals at the University of Pittsburgh. So I am an associate professor of medicine at Pitt. I'm a decision scientist by training, and my research life focuses on kind of developing processes and tools and communication strategies. Sorry about that. To support people making informed decisions about their health and well-being. And so I lead an equity-focused sexual and reproductive health technology initiative at the University of Pittsburgh. And so today I'll be talking about our work on an app that we're hoping to make freely available for all new birthing parents in Pennsylvania. It's called Mayana, which stands for Mothers, You Are Not Alone. And so I also recognize some kind of familiar faces and partners on this work in the Zoom. So thank you for your patience while I show some work that may be familiar to you. And so I know this group is intimately familiar with the abysmal maternal health statistics in the US, and Dr. Ramirez already kind of walked through some of that just now. These statistics and kind of many of the delays in diagnosis, and I don't know why I keep saying that, diagnosis and care delivery are what motivated our work to develop tools that give birth-giving people kind of better information, support more relevant contacts with healthcare providers, and then offer more precise and ideally unbiased risk identification, connecting people to appropriate resources in pregnancy and the postpartum period. I'm so sorry. I think I have it on some kind of timer to keep me to 10 minutes, but it might keep racing through slides, and I'll just I'll try and go back when I need to. Sorry about that. So Mayana is a tool that we developed initially to triage acute symptoms and provide maternal wellness support, including screenings for postpartum individuals. And then more recently, we've incorporated content to foster positive parenting and infant thriving in that first year after birth. So I think it's been about 18 months now that our team at Pitt have been working with DHS and the wonderful Sarah Goulet to make make Mayana into this tool that will be freely available to all new parents in Pennsylvania. So Mayana actually grew out of initial work that was focused on supporting healthy pregnancies. So we built the My Healthy Pregnancy platform to identify and intervene on pregnancy-related risks in a more timely way than routine prenatal care allows for. So I just wanted to quickly show you My Healthy Pregnancy, partly because some of the evidence we've collected using this tool gives us a nice glimpse into the potential that Mayana has to improve health outcomes. And because I started thinking about Mayana when people would ask me if there was, like a postpartum component that they could continue with after they'd finished using My Healthy Pregnancy. So briefly, My Healthy Pregnancy is a digital platform. It has an app that you can use during pregnancy. You can see it on the left side of the screen. And then there's a portal for clinicians that you can see on the right side, and which can be integrated with the patient's medical record through the cloud. And it collects patient-entered data for real-time analytics and sends critical alerts to a dedicated care team. So these are things like suicidal ideation, or if someone is reporting signs of going into preterm labor. It also provides patient-centered and system and community-based resources that are tailored to the individual and to the point of gestation of the individual using the tool. And so we rolled My Healthy Pregnancy out in our UPMC healthcare system at the end of 2019, and we evaluated it for a couple of years. During that time, it was prescribed to 18,000 patients, and we found that it was most used by patient populations that historically experienced disparities in care, minoritized patients, and those with the highest baseline risk factors. So these are things like a history of previous pregnancy loss or a history of mental health issues. And I've just posted here in these kind of quote boxes a few of our key findings, because we're really here to talk about Mayana today. But patients who use My Healthy Pregnancy were able to attend more prenatal visits. They had better identification of risks like preeclampsia and depression and intimate partner violence. And that allowed us to get them to care more quickly and effectively. People who used our tool often ended up having longer pregnancies and had better infant outcomes. So it was pretty impactful for our patient population. And it really kind of inspired us to extend the work that we were doing into the postpartum period. And just to the point that was raised earlier about preventive care and mental health, we've been able to use data from My Healthy Pregnancy to develop a risk screener that can identify in the first trimester individuals who will develop moderate to severe depression either later in their pregnancy or postpartum with kind of very high accuracy, sensitivity, and specificity for those individuals who are not showing current symptoms, who score fine on their PHQ-9, don't have a history of depression, but that still should be, kind of triaged into a higher risk patient category. Okay, so turning over to, whoops, oh my goodness, I'm so sorry. Turning over to, maybe what I'm going to do actually is just pause for a minute and try and reload the slides again so they don't keep jumping around on you all, because I don't want to give you slide whiplash. Okay, sorry about that. Okay, so I think I'm just going to show you a 2-minute video about Mayana, our postpartum tool, so you can see what it's like and what its functionality is. And if you have any trouble hearing it or seeing it, please let me know. So this is it.
It's like they send you home with an infant. It's like, hey, good luck. There's no information. Like you don't know what's normal. I'm a first-time mom. And you're literally left with Google at 2 a.m. to figure out what's normal and what's not. It's kind of sad.
In the United States, our statistics related to birth are much worse than in other countries that have similar healthcare resources. Black and brown people in the US are twice as likely to experience poor pregnancy or birth-related outcomes. More than 25% of moms face challenges engaging in follow-up care after giving birth, often because they have limited time or support. The first few months after giving birth are vulnerable, physically and mentally. Often, moms have little or no contact with their own healthcare provider during that time. We want to do something to support moms and guide them during that critical period. Mayana is an app designed to support postpartum healing for mothers and positive parenting to help them and their baby thrive in the first year. It includes daily topics, a symptom tracker, baby milestones, articles, and resources. Daily topics share a little information each day about things like physical healing and comfort, mental health, baby feeding, sleep, and later developmental milestones and activities for mom and baby. In the first 6 weeks, new moms can answer questions about their symptoms. They'll get a report to help them understand what's normal and what might be cause for concern. The app provides information about baby milestones and gives mom the chance to check in at key moments to keep up with how their baby is growing. A collection of articles is always available when someone wants to learn more. The information in the tool is clinically validated and comes from a trustworthy source. Finally, a list of useful resources is available for a wide range of needs that new moms might experience in their baby's first year. Mothers in Pennsylvania shouldn't feel alone at such a critical time in their lives. They deserve support, information, and resources to help them thrive on their motherhood journey.
Official app is really great that you're focusing on the mother. No one ever focuses on the mother. It's the baby. Once you give birth, it's not about you anymore. It's the baby. Everyone visits, everyone asks. It's always the baby, not how you're doing or feeling. It's always the baby. So it's good that you put that in the forefront.
Mothers, you are not alone.
Well, okay, so oh gosh, I don't know what's going on. Yeah, I'll try and pull, it doesn't want to stop. So I think here I can just kind of talk through, I think, what's going on with the slides. I'm not sure, but basically, we've been kind of working on Mayana for a few years now. I could spend kind of hours talking about the painstaking work that's gone into Mayana, but I'll just say that we've built it with a highly stakeholder engaged approach to developing content and to refining the features that are in the tool. The philosophy for all of our tools is to make sure they're giving kind of the best clinical information to people and the best resources to support them, but doing it in a way that makes sense to the users of the tool. And so that's meant kind of all different ways of gathering data to understand what our app users need. So we've done kind of focus groups or sending them home with the app and a little video camera to record their experiences while they've been using the tool. And we've just, we've been incredibly fortunate to work with a team of experts and advisors build it. And so our plan is to have a final version of Mayana ready to launch for all birth-giving parents in the spring of 2025. And we would love for you all to be part of that launch. And so I very briefly, I see a few areas of potential where Mayana can do good, and for potential for partners on this call to leverage it. And so I think if enough people are using Mayana in the state, then we can use the data that they share with us, with their permission, of course, to kind of track public health patterns that may be more nuanced. So not just looking at kind of prevalence of health outcomes, but also the certain experiences that people are having that are associated with health outcomes, because that's the kind of information that you can share in a tool like this. Really, your thoughts, your feelings, the things that are stressing you in that moment or during that period of time. We can also use the tool as a way to reach people when needed. So we did this with My Healthy Pregnancy. We launched it and then COVID struck. And so we were able to quickly, embed symptom triaging for COVID and get people to care or to stay at home before we had vaccines and when our hospitals were overrun. So you can use a tool like this to really tailor public health messaging and kind of triage symptoms, and also to understand what symptoms people are commonly experiencing that may not be part of regular clinical screening and maybe should be. So again, I think during COVID, we actually noticed in our data before COVID was widespread, like sudden spikes in fevers among our pregnant patient population, and we were not quite sure what was going on. And then we made the connection. We can use the data that we collect, that people consent to share with us, to develop new risk prediction models. And so I mentioned the kind of new, it was a machine learning based screener for identifying individuals at risk of depression. I'm working with computer science colleagues at Carnegie Mellon to develop precision preventive care treatment options as well for people. So knowing which treatments will work best for individuals before they become fully symptomatic. We can use Mayana to kind of engage people in specific resources that we want to make available to them. And so I wanted to share that with you all in case there are things that come to mind that you want to be connecting people to or promoting. We can also use the data to identify gaps in resources for individuals depending on where they are in the state. And then, lastly, I think we can create personalized resource recommendations. So which resources that are available to people will work best for them in their situation. So our next steps are statewide implementation and evaluation. We want to operate through a kind of health equity implementation framework lens, and we really welcome feedback and collaboration on this step. So we want to know, who should be at the table thinking about disseminating Mayana, what organizations or individuals might be kind of implementation facilitators, any other feedback. And I have a QR code. Let me see if I can just share this one last time. I have a QR code. If anybody is interested in kind of finding out more or joining us, that would be absolutely wonderful. And I can also at some point drop a link in the chat. So let's see. Let me just share this.
That's great. And while she's sharing the QR code, I just want to ask people, if you have questions, to put them in the chat, and we'll make sure to get them answered and share the answers with everybody, because we probably won't have time today to do a live Q&A. But go ahead, Dr. Krishnamurthy.
Are you able to see and click on that QR code? And I can absolutely send a link out to everybody, but really appreciate your time and patience with my wacky slide situation today.
Great. Well, thank you so much. I know I'm interested in learning more, and I'm sure a lot of other people are too. So that's the challenge with these meetings. We're trying to just give a little taste of these great projects that are happening, and we'll hopefully be able to follow up with more information in the future. And in that vein, we're going to move on to our second presentation today. We're going to hear about the Health Education and Legal Assistance Project, a medical legal partnership, from Shannon Mace. Shannon, are you ready to go? And I'm going to share your slides, right?
Perfect.
Give me 1 second.
Can folks hear me okay? Thank you. Well, hello everyone. I'm Shannon. I am the Executive Director of Health Education and Legal Assistance Project, a medical legal partnership at Delaware Law School, Help MLP for short. Thank you for the opportunity for letting me share our work. I have a lot of information on my slides. I won't cover it all in 10 minutes, but I put it there so you all can review it later when the slides are shared. And you can go to the next slide. Okay, so the last time this collaborative met, we answered a survey question about some of the greatest needs in the state to support maternal health. And I'm pretty sure I was the only person who chose legal services as an option. And admittedly, I'm biased, but there is a real significant need for increased access to legal services, which is particularly important for pregnant and parenting families. In the United States, 74% of families with low incomes experienced at least one unmet civil legal need in the past year. 39% experienced 5 or more needs, and 20% experienced 10 or more needs. You could go to the next slide. And despite this high prevalence of legal needs among families with low incomes, it's incredibly difficult to obtain free or affordable legal services. 92% of people with low incomes did not get any help for their unmet legal needs. 53% didn't know where to find an attorney, and almost half of all requests to civil legal services organizations are rejected due to limited resources. Next slide. And when we're talking about unmet civil legal needs, I'm not talking about helping a person file a patent or something. We're really talking about ensuring families' basic needs are met. In our world, we use this term health harming legal needs, which are legal needs that lead to poor health and can be especially detrimental during pregnancy, infancy, and early childhood. And you'll see this list here. These really are the social and structural determinants of health that can lead to poor health outcomes. Things like poor housing conditions, income insecurity, intimate partner violence, child welfare involvement, pregnancy discrimination, racial discrimination, issues related to immigration status, and the list goes on. Next slide. So Help MLP was established in 2009 to develop collaborations with public health partners to better identify and address those health harming legal needs. Our main goals are to identify unmet legal needs early among pregnant and parenting families through regular screening, improve family stability and health by resolving those unmet legal needs, strengthening the advocacy capacity of public health partners through training and education, and improving community-wide outcomes through systemic advocacy and policy change. Next slide. And since we started in 2009, our work has expanded significantly. We currently have 3 partnerships to serve families in Philadelphia and Delaware County. The Family Advocacy and Integrated Resources Project, or FAIR, serves families participating in maternal and child health home visiting programs in Philadelphia. Our medical legal partnership at the Foundation for Delaware County serves the foundation's public health programs. This includes Nurse Family Partnership and Healthy Start, and a housing program that they have called HOPE. And most recently, we established a SOAR project. SOAR stands for SSI Outreach, Access, and Recovery. And this is supported by the Delaware County Department of Human Services, and it's focused on assisting people with disabilities who are at risk of homelessness to obtain benefits. Next slide. And I just want to say that none of the work that we do would be possible without our incredible team and our incredible partners. And if there wasn't a competing holiday party right now, I would certainly have a few other folks with me to present this work. It's really all the credit goes to the team and the partner. So in front of you are our lovely team in Philadelphia who are amazing. And you can go to the next slide. And this is our team in Delaware County, also amazing. And you can go to the next slide. Help MLP's approach to legal services delivery is really focused on being collaborative, holistic, preventive, We specialize in remediating the legal needs that impact maternal and child health. We've really focused on honing in and developing that expertise. Our team considers themselves generalists, lawyers, and paralegals with a strong referral network to specialty services. The majority of the legal issues that we resolve are related to income security and housing security, of which I would say our team are certainly subject matter experts in, but we do handle cases across a range of issues, and I'll describe what that range is in a minute. And we've also tried to cultivate really strong partnerships so that we can provide warm handoffs and connections to vetted folks in the community to make sure that our clients get the services they deserve. Our model also focuses on providing continuity of representation. In typical legal services models, someone might call a hotline, they might connect with an attorney and get a service. And then maybe in a few months, they have another issue, they'll call the hotline again, they might connect and it might be a different person or they might not get help. Because we're working with home visiting programs, those participants are enrolled in their programs anywhere from 6 months to 18 months and beyond. And a trusting relationship has already been built between the home visitor and the participant, which helps us already have an in to start to develop a relationship with a client. Once we have that introduction to a trusted person, the lawyers and paralegals get to work with the families over the entire duration that they're in the home visiting program. So this allows for a more trusting relationship where issues can be discussed more openly and crises are really prevented because issues are identified sooner. And ultimately, we're really trying to lower stress through quality services and accessibility of those services. Next slide. This is our referral pathway, just a few important things. We start with training, both our team training our public health provider partners and them training us. All of our services are first, we're given informed consent and permission by the clients, both to screen them for unmet needs and to make referrals. And then we have a typical process. And I'll just mention that we do have a robust evaluation that includes collecting data from participants after cases have closed. Next slide. So we screen for legal needs across 5 domains: income and insurance, housing and utilities, education and employment, legal or immigration status, and personal and family stability. And our team provides services across all 5 of those services, all 5 of those legal needs areas, excuse me. Our home visitors are the ones who are conducting the screening. We recommend that they screen their families upon enrollment to their program and at least annually. And we do provide a lot of time doing training on how to effectively conduct screening and making referrals. So we want to make sure that screening is done in a manner that's trauma informed and centers the client and is led by the client. And on the little snapshot is just a snapshot of our electronic screening form. You can go to the next slide. Training and education is another big component of our project. We provide regular training, education, technical assistance on social, legal, and policy issues that impact pregnant and parenting families. There's a list of some of the topics that we've covered. And we've also created an electronic request form. So at any time, any of our partners could submit a request for a particular training topic, an area of technical assistance, wanting to connect with another partner that we respond to really within a business day. Next slide. So I'm just going to talk a little bit about our projects, and I'm happy to provide any other follow-up information. The FAIR project is our largest project right now. It's supported by the William Penn Foundation. It's operated by the National Nurse-Led Care Consortium, Help MLP, and Public Health Management Corporation. And it serves families participating in those home visiting programs that are affiliated with Philly Families Can, which is a consortium of home visiting programs in Philadelphia. And the FAIR project offers 2 core services to families: legal services from Help MLP and emergency financial assistance through a family support fund. Next slide. I'm not going to go over this. I just wanted to provide it to you to refer to later if you're curious, because this is a large, complex project with a lot of different partners, so you can see how things like the advisory group works with the leadership team and the various other stakeholders. Next slide. The Fair Project Family Support Fund has been a really critical component. It's operated, like I said, by NNCC and PHMC. It provides low barrier, rapid response financial support to help families meet their goals and to prevent crises. The Help MLP legal team collaborates regularly with the Family Support Fund team. So our goal is that families only use those family support fund dollars when they absolutely need to. So, for example, if a family has a utility shutoff notice, the legal team is going to provide services first to see if there is a way to get that debt resolved another way, enroll them into a consumer assistance program, something else. And then that way, that leaves those family support fund dollars that are available for that participant to be used at another time to prevent another issue. And the fund really supports a wide range of needs: housing, utilities, clothing, food, transportation, childcare. I've seen school uniforms, schooling. They're very broad in what they will cover. Next slide. I think I've already mentioned the eligibility of families who are participating in these home visiting programs, so you can go to the next slide. Our partnership at the Foundation for Delaware County was our first partnership established in 2010, and that started actually through
Oh, it looks like
okay, I guess today the technology
there you are.
is not good for anyone. I don't know what happened, but I will just say our first partnership started through a Health Resources and Services Administration pilot grant to start medical legal partnership in Healthy Start. And in Delaware County, we have expanded our work there to all of their public health programs. And you could go to the next slide. I'm just going to mention for folks who might be eligible for our SOAR project, that could be any Delaware County resident. It doesn't have to be a home visiting participant. And I could provide additional information about how to make referrals to that for folks who are working in Delaware County. You could go to the next slide. I have a lot of data here. I'm not going to read it all to you. We are conducting a pretty robust evaluation, but just to highlight a few things. In Philadelphia, the last year I have data for over 1,100 legal matters were resolved for 556 unique participants. The team obtained $533,000 in annualized financial support and benefits. If you include the financial support from the Family Support Fund, that brings it over to over $800,000. Public benefits were attained for 53 families. Evictions were prevented for 42 families, so on and so on. So you can see that we're really trying to focus on improving the conditions that folks are living in. Families report really high satisfaction with the project, lowered stress, improved quality of life, and improved relationships with their children as a result of these services. You can go to the next slide. And this is similar type data for Delaware County. I won't read it to you. And you can go to the next slide. I've also included some quotes here. Feel free to scroll through those. Yeah, you can go to the next one. And you can go to the next one. And I've also provided folks some case narratives just so you can get a better sense of what this looks like on the ground. And feel free to skip right through to the end where the resources and my contact information is. Yep. So feel free to check those out. I can drop my email in the chat as well. And sorry for the technical problem. And thank you.
Great, thank you so much. And sorry, we are rushing through these presentations to be able to get them in, but hopefully you're learning a little bit about some really great programs and you can follow up later. And again, use the chat to ask any questions. We do have maybe a minute or two, so if anyone has a burning question for either Shannon or Tamar that they want to throw out there, I'll entertain it and then we'll move on to the breakout groups. Anyone have any?
Thank you, Scott. We do have a couple questions that we're going to discuss on the breakout room. We're going to give out like 15 minutes, and then please pick a group member that would be able to report back out when we come back to the main room.
Okay, so with that, let's go into the breakouts. Thank you again to our two presenters. We really appreciate hearing about all your great work. We're going to go into breakouts for about 10 minutes. We have questions that were included in the agenda, but I'll read them now and we'll put them in the chat. They are: what clinical innovations are needed to address both the parent and child's health during the well-child visit? What are the barriers that currently exist, and what can organizations and practitioners do to overcome those barriers? Thank you, everybody, and welcome back. I think I'm going to turn it over to David Saunders to do a little bit of reporting out for the breakout groups.
Yeah, I guess, how many groups do we have?
5.
5. I guess I'll go to group number 1. Any key takeaways from group number 1? Note taker, perhaps, from group number 1?
I think that was our group, David.
Oh, why don't you do it then, Emily?
Yeah. So a few key takeaways. Had some good conversations surrounding the barriers and solutions to overcoming those barriers. Those 2 questions. It was discussed first from an electronic health record perspective, that the information that is placed in the child's chart doesn't go directly into the parent's chart. So if they're inquiring about a parent's well-being, it just kind of sits in their child's chart and is noted, and then isn't put into the mom's, for example, medical chart. Not having enough time for the appointments. Some feedback was that pediatricians already don't have enough time, they feel, during those visits to focus on the child, let alone considering the parent's well-being as well. And also just not having the resources. So if a mother were to say yes, for example, to a mental health screening with questions regarding depression, what can that physician then do with that information? They may not have resources like a social worker in the clinic who would be able to then further connect them with necessary resources. Solution-wise, just making sure that we're connecting clinical staff or clinical organizations with social services in their area and having those staff inside the clinics themselves. And transportation was another big barrier that may keep parents and children from well-being visits, and being able to provide transportation, sometimes through medical insurances, to get to these medical appointments can help overcome that barrier.
Thanks for that, Emily. I know, Scott, we are running out of time. We're supposed to finish this up at 5:02. How about we do this? For each group that's left, 2 through 5, why don't you give me one key takeaway? So I'll go to group 2.
I'm not sure which group we were, but this is Juria Coffee. One of our key takeaways, our innovation was looking into telehealth mobile clinics or home visiting nurses to be able to care for our mothers. But we were looking into the fact that insurance funding and access to local resources to be able to connect families through a web of support could be a barrier.
Right there with you on that. We definitely need to use electronic means in this space. How about another group? Doesn't have to be in any group that hasn't spoke up yet. Just jump in.
Hey, David, it's Crystal.
Okay.
Our group was kind of on the same page as it relates to technology as well. So we noted a clinical innovation being the ability to use technology better to identify opportunities when mothers should be concerned about their health. So pushing resources to them that can be used to benefit their health. And this is also a gap area right now, technology for our most vulnerable patients and their families who may not have a phone or internet, as an example. And one of the ways that we could overcome this barrier is with more money or funding, which I think is kind of a huge barrier for a lot of different things that we want to do as far as innovation. But that was, I think, one of our biggest takeaways.
No, that makes a lot of sense. One group, one organization or type of organization, I think we might be able to, low tech wise, our library. They're pretty much in every community, and they're always very helpful. And perhaps we could have some good information there. Another group as we wrap up, and then I'm going to come to you, Dr. Ramirez.
I can go for group three.
Sure.
I'll make it quick. An intervention that I could not say is the implementation of an implicit interconception care model we talked about in the last session. So screening moms at well child visits from 0 to 24 months for basically preconception care, things like depression, tobacco use, substance use, contraception needs, multivitamins, and starting that conversation. So that's a model that is, I think, innovative and is proven to be feasible and implementable. An iteration of that is checking maternal blood pressure at newborn visits, which doesn't commonly happen at pediatric offices because of a lot of perceived barriers, but can be the only spot where somebody either diagnosed with gestational hypertension or hypertensive disorder pregnancy or not might be going in at that 4, 5, 6 days postpartum. And that might be the time where they learn that they have that condition. That's something that's not being done currently. And then I was on with Dr. Livingston, so I would be remiss to not mention that doulas can play an important role in helping families navigate in that transition period for both mom and babies, but also providing education on the front end for high-risk communities, including those immigrant communities or resettled communities for which expectations around that maternal child newborn time may be a little bit different culturally in the United States and in other places. So a lot of opportunity there.
Thank you very much for that. We'll jump right to Dr. Ramirez. I just want to say that I'm excited about this collaborative. We have wonderful, innovative ideas, wonderful folks that are a part of this group. Will only expand. I'll hand it back off to Dr. Ramirez. Very happy about this.
The mute button. I'm like, where is it? Well, thank you, David. So thank you everyone for participating for this exhilarating conversation. Our goal for the next meeting, part of it will be to demonstrate our collaborative strength and number and who all is represented here. As I mentioned earlier, I didn't know who Giselle was and who she represented. So that's going to be another goal, is to really get to know who each of you are and figure out what are your strengths and what voice do you bring to this table. I'm actually going to hand it off to Scott to drive it home for us as our lead organization. Scott?
Sure. Thank you, Sarah. And thanks everyone for joining. I think this was another great meeting and bigger than last time. And we have a lot more people on our list. As Sarah mentioned, we're trying to kind of get a handle on everybody who's out there, partly to learn more about you, but also to figure out who's missing so we can invite them. I did put a link in the chat about a short, simple form we were asking everybody to complete about their program or their institution or themselves so that we can start to kind of look at that information. We tentatively have decided on a next meeting date of March 7th. We will confirm that with everybody, but we're looking at doing this quarterly, and in between then, we will be posting the meeting recording, posting the slide sets from the presentations, and probably communicating out to you all a few times just to ask for updates and share information as we get it. So with that, I think we're going to adjourn and watch for more information from us about the recording and about the next meeting in March. Have a great day, everybody, and thanks to all our presenters.